may affect severely in professional voice users or even teachers or lecturers like myself. Okay, so why do we have to have a standard basic assessment of voice? It is so that we have a better agreement and uniformity in reporting voice assessments, so that we communicate, or we are speaking the same language between the clinician and also the researchers. So first is when we want to publish results and compare the voice treatment outcomes. And also when we have some new instruments or new technique, we want to evaluate whether it is successful or not, and to compare the results of voice treatment across the studies by performing a meta-analysis. A good voice assessment, like I mentioned just now, consists of, it should be multidimensional. Okay, so European Laryngological Society has produced a very nice paper on the basic protocol of voice assessment, which consists of the perceptual voice evaluation, self-reported outcomes by the patients, aerodynamic assessment, acoustic analysis, and laryngeal endoscopy. So before we embark on assessing the voice, we have to record a voice sample. So in a voice clinic, recording a voice sample is a prerequisite. It allows blind perceptual evaluation by a panel of experts later, and also it allows for acoustic analysis, which is run by the softwares. Okay, and also it has a medical implication. So whenever the patient questions about our treatment, we can show back our previous recording before the treatment. Okay, so recording a voice sample, the patient should be comfortable speaking in conversational speech, and we have to use a standardized, validated text. Okay, and the environment should be a sound-treated room, a quiet room, preferably less than 45 dB. And we have to ensure the distance between the lip and also the device should be in a constant, which is the recommended distance is 30 centimeter, about hand span of distance. And we also have to pay attention, so don't only focus on the voice, we have to pay attention on whether is there any breathing effort, is there any stridor, is there any pauses in between the sentences, how about the articulation of the patient. Okay, so in our voice clinic, we do record their voices in every patient. So every voice patient, we will record the voice. This is a photo of my beloved postgraduate student. She's now a specialist. So as you can see in this photo, she makes sure that the device is at the same level of the mouth, okay, and the distance is kept constant, about 30 centimeter, and we have to remove the patient's mask if possible, and make sure the fingers is not covering the microphone, or else you will not be recording any voice. Okay, for voice recording, we use the validated standard text, which is phonetically balanced. In our clinic, in our practice, we use two type of passages, which is the Rainbow Passage for English version and Kampungku. Kampungku means my village for Bahasa Malaysia version. Kampung saya. Okay, next one is the auditory perceptual voice evaluation, which is a subjective voice assessment rated by the professional rater using a validated scale. So the rater should be well versed about the scale, and the most commonly used is the GRABA scale, which is by Hirano. It consists of 4-point scale from 0 to 3. 0 is normal. 1 is when you really have to listen to the voice to detect the abnormality. 2 is when the voice deviance from the normality is occasionally, and 3 is when you can detect the abnormality immediately as the patient speaks. So G stands for grading. Rough is vocal fry, when there is pathological structural pathology in the vocal fold, such as glottic lesions. Breathiness is due to glottic insufficiency, due to air leakage through the glottis. Asthenia is when the voice is weak, and also strain is when the voice is in a hyperfunction state. Okay, and roughness and breathiness has the highest inter and intra-related reliability with the grading. Okay, let's play.
Semasa saya kecil, saya tinggal.
What do you think about the voice?
Bersama nenek.
Okay, so it is grade 3 with the main component of strain and also breathiness.
Saya masih kecil, saya tinggal.
Okay, so grade 3 with the main component of straining and also roughness.
When the sunlight strikes raindrops in the air, they act as the prism and
I would say it's grade 1 with the main component of roughness. That you really have to listen to it, to know there's roughness. So this is how the voice recording should look like. Preferably to remove the patient's mask. You should be able to, visualize the patients from the head, neck, upper part of the chest as well as half of the shoulder.
Semasa saya kecil.
Okay. So another auditory perceptual evaluation is a CAPE-V, which is actually a vast score, visual analog score rated upon a completion of multiple voice tasks. The clinician will indicate degree of perceived deviance from the normal using a tick mark. So this is quite tedious as compared to the GRABA scoring, but it's more popular among the speech language pathologists. Okay, now is the patient self-reported outcome. So different patients with the exact voice disorder might perceive their voice differently. So that is why we need the patient self-reported outcomes, because their vocal demand are not the same. So it is probably, to me at least, it is the most valuable tool to assess a patient's voice, which is based on the questionnaires. Okay, and there are questionnaires with high ability and internal consistency, the VHI, the voice symptom scale, and also the voice-related quality of life questionnaires. And the most widely used questionnaire in the literature is the VHI-10, and we have also translated and validated in Bahasa Malaysia version, which showed high reliability and validity. And for our region, for Malaysia, the cutoff point, or the normative cutoff point is 7. Okay, as Ms. Nora mentioned just now, to generate a good voice, you need to have a good aerodynamic or respiratory function. So how do you assess aerodynamic assessment? First is using a maximum phonation time. You can assess the patient's lung function test by spirometry, as well as a more sophisticated device to measure the phonation threshold airway pressure subjectively, where a device will measure the average glottal airflow, subglottal air pressure. Okay, so maximum phonation time, it is very simple and most commonly used. It measures the glottic sufficiency. You just ask the patient to say ah for as long as possible after a maximal inspiration and at a spontaneous, comfortable pitch for the patient. So some may ask, do you prefer ah, oo, or e? I think as long as you use the same method for every assessment, then it should be okay. But in our setting, we use ah. Okay, and it measures in seconds, and we take 3 trials and take the best duration possible for the patient. And to do maximum phonation time, you have to make sure the patient is fit to do it. So don't do maximum phonation time in a patient who have stridor, or the patient with with oxygen, and also patient with tracheostomy. Okay, so for our data for Malaysian. The normal maximum phonation time ranges for 15 to 21 for male and 13 to 18 for female. Okay, as part of multidimensional voice assessment, we need to perform an objective assessment of the voice, okay, which is an acoustic analysis. It is a quantitative, non-invasive, computer-based objective assessment of voice using a multiple type of software. There are many softwares in the world to assess or to produce acoustic analysis. So it provides indirect inference regarding the underlying pathophysiology of the voice disorders. So among the parameters that we measure are fundamental frequency, which is the mean frequency of the vocal fold mucosal vibration, jitter, the variation in frequency, shimmer, variation in amplitude, and noise to harmonic ratio, measurement degree of hoarseness. So to perform acoustic analysis, you need a few basic instruments. Number one is the microphone. It can be a head-mounted microphone, it can be unidirectional or omnidirectional microphones. But head-mounted microphone has the advantage of, the distance between lips and the microphone is always kept persistent. And then the next part is the microphone preamplifier, and last but not least, the software, the computer software that can diagnose and can produce the acoustic analysis. So here, which is the MDVP, multidimensional voice program, which we are using currently, like recently, and then OperaVox. OperaVox is a software that is installed in an airport. And it can be used to measure the acoustic analysis. And Pratt is a computer software that can be downloaded online, which is free, but I don't have experience with Pratt. So this is an actually old photo. Previously we used Opravox to measure the acoustic analysis. As you can see, it is done in a soundproof room. Patient will wear a lanyard to keep a standard distance between the lips and also the device to record the acoustic analysis. And a few tasks that we ask the patient to do is to produce a sustained R for 3 to 5 seconds so that the software can analyze the acoustic analysis. We ask the patient to read a standard passage. Loudness range, we ask the patient to do a loudness glide as well as the pitch glide. Okay, lastly, laryngeal endoscopy. So to get use the larynx, you have to have a direct view of the larynx because larynx is something that's dynamic. So it can be done using a rigid scope or flexible nasopharyngeal laryngoscope. It is the main clinical tool to examine to diagnose as well as to evaluate the effectiveness of the treatment. And we also have to, have a complete head and neck examination. We have to also evaluate the confounding factors such as any nose pathology, whether there is any post-nasal drip, how about the oropharynx, and also on. Okay, so in our practice, we ask the patient to sit comfortably, slightly bending forward, and then the head is also slightly forward to produce so that the larynx will be in a straight position. Okay, so for flexible nasopharyngeal laryngoscopy, okay, first we have to have a bird's eye view. We call it drone view. Okay, and then when the patient says E, you go closely to the vocal fold to have a personal visualization of the vocal fold. Okay, look for any gross structural characters. How about the position of the vocal fold, the mobility, the arytenoid position, and whether the vocal fold has atrophy. Okay, so in resting position, adduction, when you ask the patient to say E, you can assess the mobility, the adduction of the vocal fold, as well as whether there is any supraglottic squeeze. And you ask the patient to sniff to assess the abduction. Okay, and don't forget to test for laryngeal sensation as well as look for any LPR features. Okay, laryngostroboscopy. So do not be confused between laryngostroboscopy and laryngoscopy. So laryngostroboscopy is a device that is connected to a laryngoscope. So it can be connected to a rigid scope, it can be connected to laryngoscope, so that it can produce a slow motion of the vocal fold mucosal vibration, so that we can assess precisely the vibratory characteristic of the vocal fold. Okay, when the flashes of light matches or exceed the frequency of the vocal fold vibration, it will delay and produce a slow motion video. As you can see here, the amplitude is reduced. Okay. Okay. So these are the parameters that we assess during laryngostroboscopy, which is a mucosal wave, whether it's symmetrical or asymmetrical. The amplitude is lateral excursion of the mucosal wave, whether it is limited or to laterally. The periodicity, whether there is any non-vibratory segment, and also duration of closure. So this will be further explained by Prof. Marina in the next lecture. Okay, so I'll just show. Okay. Okay, that's the vocal polyp. As you can see, on the left-hand side, the left vocal fold, there's presence of pedunculated polyp, which impinge on the contralateral vocal fold, causing limited in the amplitude of the mucosal vibration. Okay, this is another tips. When the patient is having a very bad muscle tension dysphonia, it's difficult for us to visualize the vocal fold, isn't it? So what you can do, okay, so look at the left side. You cannot really visualize the left vocal fold because of the supraglottic squeeze. You can ask the patient to say ooh, or perform the blowing exercise so that can visualize the glottic better to reduce the muscle tension dysphonia. Okay. So I think that's the end of my slide. So in conclusion, voice and laryngeal ablation is a paramount for diagnosis, treatment selection, and also to monitor the treatment effect. It should be assessed multidimensionally, and video laryngostroboscopy is essential in clinic. But if you don't have stroboscopy, the minimum assessment that you need to do is the Grabas scoring, which is auditory perception of voice evaluation, VHI-10 to see the patient perception of the voice problem, maximum phonation time to assess the aerodynamic function, and also laryngoscopy to have a dynamic or direct view of the larynx. Okay, with that, I thank you.